Good evening. Chaturbhuj, you are in Baroda or you shifted to Ahmedabad?
No, sir, I am in Baroda only. The Jaidas Hospital has opened in Baroda, so I have joined that.
Okay, okay.
Oh, shifted it.
Cool. So, Chandrasekhar, I will leave at 6:45. I have Dimag Pe Charcha at 7 o'clock.
Yeah, I saw that with Sanjay Singh and MM.
Yes. So I need to leave that. And 8:30 is Dr. Ujjwal Rao doing the awareness campaign for the East. So a lot of activities Secretary Saab has organized all over country. Everybody is busy.
President.
I must say, sir, this is first time I am seeing so much of activity. At least people might have been doing this, but it was not in the limelight at the national level. So
I hope this creates an atmosphere.
No. Last year we did at national level, but the peripheral level was not done. Last year we did a lot of activities, but the other centers were not, following. So this time the other centers have taken over.
sure, sir.
So that's a very good sign.
I think first time, sir, joint combined effort it looks now this time.
Yeah.
No, COVID has also been
So it looks good.
It has come down, so people are more active this time.
Yeah.
Now, I selected 60 people across the country. 36 replied. Still, there are people who have not replied. So we'll catch hold of them also by next month. We'll try.
Gagan, good evening.
Hi, Dinesh.
Dr. Dinesh,
Hello.
good evening.
Hi, Dinesh. Dinesh is probably in remote area of somewhere.
He is with this Valentine in Goa.
Oh, so it's truly enjoying.
How appropriate, actually. So his wife would say, I love someone who deals with epilepsy. So,
Yeah.
good
Good evening, Gaganji.
evening, Ji. Good evening.
Good evening, Gagan.
Good evening, Dr. Sita.
Good evening, sir. Good evening.
Hi. Acha. So,
Is it still very cold there, Gagan?
yeah, you need to have something on, yes.
Okay.
Yeah, but today Prime
But
Minister
it is
has
not
come.
like,
Today
it's
Prime
not like,
Minister-
it's
Sorry,
not
sorry.
like what it was in January was really bad.
I believe PM has come to Punjab today, so now it will become hot.
Yeah. Actually, it was a very tense day. Yesterday, Amit Shah had come, and today the Prime Minister is here. He is currently here in Punjab.
Yeah, we are
So-
already open. We are already open and it's being recorded.
Okay.
Right. Okay.
Good evening, sirs. Good evening.
Hi, Dinesh.
Hi. Good evening.
Happy Valentine Day.
Thank you, sir. Thank you, sir. Thank you, Nirmal Surya, sir.
I let the secret out, Dinesh. I told
Okay. I'm in Goa now, so
We all know that.
thank you, sir.
But in Goa, you are doing epilepsy.
Sorry for Dinesh. Sorry for stealing your fun.
So it's in the presence of such wonderful. It's a great opportunity. Thank you, sir.
So one more minute and Chandrasekhar kindly take over.
Yeah. So should we start?
Yes, please.
आज इंटरनेशनल इपिलेप्सी डे है और इस अवसर पर इंडियन एकेडमी ऑफ न्यूरोलॉजी की ओर से आयोजित इस जन जागरण कार्यक्रम में मैं डॉक्टर चंद्रशेखर मेश्राम आपका तहे दिल से स्वागत करता हूं। आप सभी को इंटरनेशनल इपिलेप्सी डे के उपलक्ष्य में हार्दिक बधाई देता हूं। आज वैलेंटाइन डे भी है और इसलिए शायद आज इंटरनेशनल इपिलेप्सी डे का थीम है लव अ पर्सन विद इपिलेप्सी। पिछले कई सालों से इंडियन एकेडमी ऑफ न्यूरोलॉजी पब्लिक एजुकेशन प्रोग्राम में आयोजित करने में बहुत अग्रसर रही है। इपिलेप्सी एक दिमाग की बीमारी है और करीब 5 करोड़ लोग पूरे दुनिया में इस बीमारी से ग्रसित है। इसमें 24 लाख लोग नए ऐड हो जाते हैं हर साल। अपने देश में करीब 1 करोड़ 20 लाख लोगों को ये बीमारी है और करीब करीब 1000 में से 6 लोग इस बीमारी के शिकार हो जाते हैं। ये समझना बहुत जरूरी है कि ये बीमारी का इलाज है, ये बीमारी प्रिवेंट कर सकते हैं क्योंकि ये ब्रेन की बीमारी है। मगर ऐसा देखा गया है कि 80% जो लोग हैं जो डेवलपिंग कंट्रीज में है या अंडर डेवलप्ड कंट्रीज में है वो मेडिसिन पे आज नहीं ले रहे हैं। इसका कारण ऐसा है कि लोगों के बारे में बहुत गलत धारणाएं हैं और इपिलेप्सी के बारे में नॉलेज की कमी है और कुछ कुछ जगह दवाइयों की भी कमी है। इसलिए इस बीमारी के बारे में जानना बहुत जरूरी है। हमारा सौभाग्य है कि आज इस कार्यक्रम का उद्घाटन करने हेतु इंडियन एकेडमी ऑफ न्यूरोलॉजी के अध्यक्ष डॉक्टर निर्मल सूर्या हमारे साथ जुड़े हुए हैं। डॉक्टर निर्मल सूर्या फिलहाल कंसल्टेंट न्यूरोलॉजिस्ट है बॉम्बे हॉस्पिटल मुंबई में और पिछले कई सालों से महाराष्ट्र भर इपिलेप्सी के बारे में जन जागरण करते हैं, कैंप्स का आयोजन करते हैं। आप इंडियन फेडरेशन ऑफ न्यूरो रिहैबिलिटेशन के अध्यक्ष है और एशियाई न्यूरो रिहैबिलिटेशन सोसाइटी के उपाध्यक्ष है। इपिलेप्सी के विषय जो ये इपिलेप्सी का विषय है वो आपके दिल से बहुत करीबी का है। डॉक्टर निर्मल सूर्या आपका बहुत बहुत स्वागत है। आज हमारे साथ लुधियाना से इंडियन एकेडमी ऑफ न्यूरोलॉजी के नियोजित अध्यक्ष डॉक्टर गगनदीप सिंह भी जुड़े हुए हैं। डॉक्टर गगनदीप सिंह आपका भी बहुत बहुत स्वागत। इंडियन एकेडमी ऑफ न्यूरोलॉजी के सेक्रेटरी और आज के कार्यक्रम के मॉडरेटर डॉक्टर यू मीनाक्षी सुंदरम जो चेन्नई से हैं, जो फिलहाल डायरेक्टर ऑफ न्यूरोलॉजी एसआरएम इंस्टीट्यूट ऑफ मेडिकल साइंसेस चेन्नई में है। और इस चर्चा सत्र को संबोधित करने के लिए देश के इपिलेप्सी एक्सपर्ट्स हमारे साथ जुड़े हैं। डॉक्टर संगीता रावत जो डीन और हेड ऑफ द डिपार्टमेंट है केईएम हॉस्पिटल मुंबई में और जो इपिलेप्सी सबसेक्शन है इंडियन एकेडमी ऑफ न्यूरोलॉजी के उसके भी वो अध्यक्ष हैं। डॉक्टर चतुर्भुज राठौर बड़ौदा गुजरात से हैं और वो इपिलेप्सी सबसेक्शन के कन्वेनर है। डॉक्टर सीता जयलक्ष्मी कंसल्टेंट न्यूरोलॉजिस्ट और इपिलेप्टोलॉजिस्ट है कृष्णा इंस्टीट्यूट ऑफ मेडिकल साइंसेस हैदराबाद में और डॉक्टर दिनेश नायक इपिलेप्सी स्पेशलिस्ट और न्यूरोलॉजिस्ट त्रिवेंद्रम से हमारे साथ जुड़े हैं। आप सभी मान्यवर का बहुत बहुत स्वागत है और इस कार्यक्रम में आप सब आए हैं तो आपका सबका मैं स्वागत करता हूं और डॉक्टर निर्मल सूर्या को विशेष रूप से विनंती करता हूं कि वो इस कार्यक्रम को का उद्घाटन करें और हमें संबोधित करें। डॉक्टर निर्मल सूर्या।
Thank you very much, Chandrasekhar Meshram. The President-elect, Dr. Gagandeep Singh, U. Meenakshi Sundaram, my EC colleague, Dr. Sita Jalaxmi, Chaturbuj, Sangeeta, or Dinesh. Today is International Epilepsy Day, and we all know this has been celebrated on the second Monday of the February, and fortunately, it has fallen on a day which is a Valentine Day, very popular among the young people, and so is epilepsy, which also is very common in young people. So there's quite a correlation, and as Meshram has already mentioned to you, that this year theme is Love a Person with Epilepsy. So I'm sure you all will agree that love is needed by everybody. There's not a single person in this world who do not desire the love. But the epilepsy people are special people, and they need an extra love. And therefore, it's important that on this day, you adopt a one person with epilepsy, you have a date with one person with epilepsy, or give a chocolate, or give a flower, or just give a hug. So that could spread a confidence and an affection to the person who is suffering, and his suffering will reduce, and he will feel that something good has happened to you. Indian Academy of Neurology, as Dr. Meshram has mentioned to you, has been very active in creating an awareness. And especially today, I'm very glad that from yesterday only, various chapters across the country has started. And yesterday, Sikandar Advani at Amravati did a very big program where more than 125 caregiver and people with epilepsy participated. Dr. Meshram was there, and I myself has inaugurated that meeting. Today we had a couple of meetings already done, and again there are 2 more meetings to be held in different parts, like in East, South, North, and then tomorrow we also have another meeting by Dr. Alam. So various neurologists across the country has become very, very active to create an awareness. It doesn't mean that we are just creating awareness. It shows that we are sensitive about the disease epilepsy. We want to reduce the treatment gap, which in rural area is to the tune of 75%. And I have made a model in Maharashtra where if a systematic treatment is being planned, the treatment gap can be reduced from 75% to 25% easily. And I think all the neurologists across the country has been trying to do that. And the key factor in reducing the treatment gap is creating an awareness. And I'm sure the panelists, what you have today, are absolutely expert in their field. They are going to give you certain tips. Chandrasekhar Meshram will add on to that. He is one of our experts, and if anybody wants to see what kind of seizures can be there, semiology, he can show you exactly that. We have done it in my two of my program, and it's very impressive. So he can just simulate what sort of an attack it would be. So it may be very useful that Chandrasekhar shows you one of the attack which can easily be diagnosed, because diagnosing an epilepsy is by history, and the witness are the one who can diagnose, and therefore it is very, very important that correct diagnosis and early treatment is started. So with that note, I hand you over, Chandrasekhar. I wish you all the best, and I hope that this awareness become infectious among the neurologists, so that all over India, at least 90% from 1.2 crore, even if 90 lakhs people can be targeted and brought under the umbrella of treatment. I think Indian Academy of Neurology has done its work. Thank you very much, and I wish you all the best, and take it forward, Dr. Meshram. Thank you. Namaste.
Thank you, Dr. Nirmal Surya. Now I hand over to Dr. U. Meenakshi Sundaram for carrying out the panel discussion and further proceedings. Dr. Meenakshi Sundaram.
Thank you very much, sir. Thanks, Mr. President, for your kind, nice, very informative speech. Epilepsy, as we know, as has been really pointed out, is a not so easy disease to handle. I won't say difficult, it is not difficult at all. And it is considered very difficult by many people who are not aware of it. So our job here, with all these wonderful experts that we have, would be to take you through the many aspects of epilepsy you're free to ask your questions in the chat or something, and you would include them if possible. But we will do from the basics. As we say, I will start with Dr. Sangeeta. Dr. Sangeeta, can you tell us what is a seizure and what is an epilepsy? Are both the same? You're muted, Sangeeta. Unmute yourself. You're still muted. You have to unmute yourself.
I can't unmute it. Yes,
Yeah, you
hosted muted me. Yes, it's the whole thing. Yeah. So anyway, good evening to all, and thank you, Dr. Sundaram, and happy International Day to all, and also happy Valentine Day to all the viewers. What you have asked is a very valid question. Is seizure and epilepsy में definitely दोनों अलग चीज है. जब सीजर ये होती है कि जब ब्रेन में अचानक इलेक्ट्रिकल डिस्चार्ज बढ़ जाता है, तो एक सीजर आता है जिसमें अलग अलग प्रकार के, बड़ा फिट हो सकता है या फिर छोटा कंफ्यूजनल वाला फिट हो सकता है या आंख चमकाने वाला भी, बट ये एक फाइनाइट इवेंट है. अगर ये कुछ बुखार की वजह से आ गया या कुछ सर पे चोट लगने से आ गया, तो उसको प्रोवोक्ड सीजर बोलते हैं. तो एक सीजर आती है, उसके बाद बंद हो जाती है. मगर ऐसा कोई प्रोवोकिंग फैक्टर नहीं हुआ और बार बार फिट आती रही, तब जाके उसको 2 से ज्यादा फिट ऐसा अनप्रोवोक्ड सीजर आया, तब जाके उसको एपिलेप्सी बोलते हैं. सो एपिलेप्सी इज लाइक अ क्रॉनिक डिसऑर्डर व्हिच कंटिन्यूज फॉर अ लॉन्ग टाइम. मगर सीजर है वो एक फाइनाइट एक ही इवेंट होता है. सो बार बार अनप्रोवोक्ड सीजर आया, तभी उसको एपिलेप्सी बोलते हैं.
Okay, so thanks for the clarification. So in short, epilepsy एक बीमारी है, it's a disease, and seizure is a symptom. So
Symptom.
that is something that would you also like to talk about convulsive and non-convulsive seizures?
Yes, convulsive seizures is like where you have a जो हमेशा लोग देखते रहते हैं, बड़ा टॉनिक क्लॉनिक ऐसा मूवमेंट होता है, एंड पेशेंट आईज अप्रोल हो जाते हैं, एंड देयर इज अ टंग बाइट एंड फ्रॉथिंग एट माउथ, इनकॉन्टिनेंस ऑफ यूरिन. सो वो बड़ा फिट है. मगर उसके सिवा बहुत सारे छोटे छोटे अलग प्रकार के फिट है. ये जो बड़ा है उसको कन्वल्सिव फिट बोलते हैं. दूसरे ऐसा आते हैं जिसमें यू में सिर्फ आई ब्लिंकिंग हो सकता है, या फिर एक आधा हार्ट सिर्फ जर्किंग हो सकता है, या फिर कुछ कंफ्यूजनल एपिसोड्स हो सकते हैं जिसको फोकल सीजर्स और फोकल सीजर्स, जिसको पहले हम कॉम्प्लेक्स पार्शियल सीजर बोलते हैं, अभी उसको फोकल सीजर. मतलब वो दिमाग के एक भाग से आते हैं और बाद में स्प्रेड होते हैं. तो वो जो भाग से आ रहे हैं वहां का सिम्टम सबसे पहले होता है. तो आपको कभी तो पेट से बटरफ्लाई जैसा लग सकता है, या फिर एब्नॉर्मल स्मेल आ सकता है, और वो उसके बाद फिर इट मे रिमेन इन योर पेशेंट अनकॉन्शियस नहीं हो जाता, बट कंफ्यूज रहता है. सो ही मे नॉट आंसर यू, but if you look at him, you may not know that it is a seizure unless the people who are staying with him will know. Uske baad he may have a lip movement like this. He may have a automatism of the hand. He may have a posturing of the hand, or he may speak sometimes totally irrelevant. Or sometimes he is partially aware also, and he may answer some of the question and follow some of the question. So this is called a complex seizure or a focal seizure with the focal impaired awareness seizure. Sometimes it is just a focal seizure and patient is fully conscious, which is called, तभी उसको बोलते हैं focal with preserved awareness seizure. So ऐसे अलग प्रकार होते हैं. Sometimes you may only have a jerk of one hand, which is called as a myoclonic jerk. So these are non-convulsive seizures. I mean, not a big this thing. And sometimes you may also have just a flickering of one eyebrow, or a flickering of one of the jaw or something, which may look like a non-convulsive seizures, which may continue for long time. So ऐसे convulsive or non-convulsive multiple प्रकार के fits आ सकते हैं.
Thank you, Sangeeta. That was a very, very elaborate answer, and that was very nice. You clearly told us about the different presentations, and so nice that I always tell patients that epilepsy is because there is an electrical problem in the brain, The brain itself is composed of wires, if you want to think like that, full of circuits. So there's an abnormality in the wiring or the abnormality in the current flowing. Then you're going to get a shock in a house. Same thing happens in the brain. And the brain is like the main board in your house. You talk about 3 phases and all that. So it does every function. From there, the refrigerator, AC, the tube light, the fan, everything works. Similarly, all functions of the body happen through the thing. So if there is a problem, you can have anything. There is an irritation, like how nicely, elaborately Dr. Sangeeta has told you. It is possible that somebody can even run, somebody can laugh, somebody can cry. So all this that you normally do can be provoked depending upon which part of the brain or which part of your main board is irritated. I think that is what is been very clearly conveyed. Thank you, Dr. Sangeeta. I would ask Dr. Gagandeep. Dr. Gagandeep, can you tell us the common causes of epilepsy?
Thank you. Thank you, Dr. Meenakshi Sundaram. That's a very important question, and we need to know that epilepsy is not just one disease. It is something that can occur due to a variety of causes. So the end result or the end manifestation is the same, but then there are a large number of causes of epilepsy. I mean, the number of causes can actually go into hundreds, but there are some common causes. कुछ ऐसे कारण हैं जो बहुत common होते हैं. So one is head injury. So अगर किसी को सिर पे चोट लग जाती है रोड ट्रैफिक एक्सीडेंट के बाद और या किसी और किस्म की इंजरी के बाद, तो दैट इज नोन एज अ पोस्ट ट्रॉमेटिक एपिलेप्सी और पोस्ट ट्रॉमेटिक सीजर्स. दूसरा, ब्रेन में अगर ट्यूमर हो, ब्रेन ट्यूमर्स, सो ब्रेन ट्यूमर्स इज ऑल्सो एन इम्पॉर्टेंट कॉज फॉर एपिलेप्सी. The third is infections of the brain. ब्रेन की कई किस्म की इन्फेक्शंस होती हैं. ब्रेन के अंदर कभी कभी एक कीड़ा चले जाता है, ब्रेन के अंदर कभी कभी टीबी हो जाती है, ब्रेन के अंदर कभी कभी एब्सेस बन जाती है. सो इन्फेक्शंस, वायरसेस करके, कोविड करके तो नहीं, बट कई ऐसी वायरसेस हैं जो ब्रेन के अंदर ही घुस जाती हैं और उस करके फिर एपिलेप्सी या मिर्गी हो सकती है. So these are some of the common causes of epilepsy or seizures. Sometimes we are not able to find a cause. कई बारी हमें पता ही नहीं चलता कि मिर्गी किस कारण है. मतलब आप जितने मर्जी टेस्ट करा लो, पर स्कैन में, एमआरआई में, सीटी स्कैन में कुछ नहीं आता, कोई इन्फेक्शन नहीं आती, कोई ट्यूमर नहीं होता, कोई चोट पहले नहीं लगी होती है. तो उस केस में फिर हम एपिलेप्सी को इडियोपैथिक एपिलेप्सी कहते हैं, राइट. आजकल उसका नाम चेंज हो गया क्योंकि उसमें कुछ हेरिडिटरी कंपोनेंट होता है, तो उसको हम फिर जेनेटिक जनरलाइज्ड या फोकल एपिलेप्सी कहते हैं. तो ये रहे कुछ कॉमन कॉजेस. और भी बहुत सारे कारण हैं, देयर आर लॉट्स ऑफ अदर कॉजेस, बट आई थिंक इट इज इम्पोर्टेंट टू नो सम ऑफ दीज कॉमन कॉजेस.
Thank you, Dr. Gagandeep. I would take it further with Dr. Sita Jayalakshmi, who's a consultant in KIMS, Hyderabad. Now that the causes, do they differ with the age of the patient, which would be the common one?
Yes, sir, definitely. Actually, when we look at the age of the epilepsy is very common at extremes of age. It's more common below the age of 2 years and above the age of 60 years. So if you look at the various ages, usually below the age of 2 years, as well as in children, the commonest causes of epilepsy are, it is something called abnormality in the development of the brain, which we call it as focal cortical dysplasias, which may cause well-controlled or difficult to control epilepsies. Similarly, the most important in our country is birth-related injuries. At the time of the birth, there is a decrease in the blood supply to the brain, or there is a decrease in the glucose concentration. That's called neonatal hypoglycemia.
and the decrease in the blood supply is called hypoxic ischemic encephalopathy. Actually, these two lead to development of a scar in the brain, that is gliosis. And these children later develop cognitive impairment along with the continuous or difficult to control seizures also in almost 70% of the cases. So these are actually preventable epilepsies. Like Gagandeep said, trauma is also one of the preventable epilepsies. So it's very important to have normal delivery and care by a neonatologist to prevent this. In addition to this, tumors also is an important cause, like low-grade tumors in case of children, which can cause the epilepsies. So like I said, scars, neonatal hypoglycemia, tumors. When we come to adults, actually the genetic causes are more common. That is the idiopathic generalized epilepsies in adolescence. And that is from the age of 12 years up to 20 to 30 years. That is the onset. And if you see after the age of, in adults actually, that is up to the age of 60 years, from possibly 30 to 60 years. The causes are, again, it can be low-grade tumors. Another important cause is something called hippocampal sclerosis. Actually, these people will have fever with seizures in childhood, and later there will be a gap of 10 to 15 years, after which they start having fits or the so-called seizures. And when they are not controlled, when you do an MRI, you identify this. That's called hippocampal sclerosis. Actually, this is the commonest cause of difficult to control seizures in adults. In addition, even the head in India, head injuries is one of the important causes, because whenever there is a head injury, patient may not develop the fits immediately, but after some time they start having seizures because of the something called a scar in the brain or gliosis. Actually, this is also one of the important preventable cause for seizures by wearing a helmet on the roads and following all the rules. These head injuries are common even in people who take alcohol. Alcohol itself can cause seizures, sometimes either because of excess alcohol intake or because of alcohol withdrawal also. Another important cause above the age of 60 years is people who have tumors, as well as stroke is one of the important causes. So strokes can lead to some, again, scar in the brain after some time, and people can have seizures during the stroke or sometimes after a gap of 3 months to up to even 2 years, and even very late after the stroke. So these are the various causes across the various ages, and so as per the need, the patients will be evaluated by the physician.
Thank you, Dr. Sita. So I'm sure all of you got the message. But what would be the common causes in different age groups, and how we approach looking for the common causes? Take this to Dr. Dinesh Naik. This is the head of neurology at Global Hospitals, Chennai. Dinesh, if a patient comes to you with seizures, what are the tests that he or she may need? And how would you go about diagnosing epilepsy?
Thank you very much, Dr. Meenakshi Sundaram, for that. It's a great privilege and honor for me to be here in this esteemed panel. Yeah, I mean, there's a very important point. You see, the epilepsy itself, this diagnosis of seizures and diagnosis of epilepsy is 90% done at the outpatient clinic level. That is the most important message that we have to convey. You don't need sophisticated investigations at the beginning. So that's the first thing. So a good history, a very detailed history, just listening to the patient and the eyewitness account is the most important. And in this era, I would say that the investigation begins with the examination of a video taken in a smartphone by the eyewitness, for example. So we should always encourage our people around, and I would encourage everybody to be aware of this, that any paroxysmal event that takes place, if you come across, today in the evening, I may come across somebody, in the street or something like that when I'm taking a walk. And if I see it, first thing is try and record it, or encourage somebody else to record it when you're actually attending to the patient. So that's the first thing, because it's a clinical diagnosis. So if we get the good idea about what the patient has, so that's the first thing. So I would say the investigation begins with that, the outpatient. Now, you have some very important investigations that are to be done. And the first thing is to get a good EEG done. Now, EEG is the only test that is going to tell us about the electrical activity. You just mentioned very nicely that the brain is, is the electrical master of the whole thing. And so it's an abnormal electrical discharge. So the only test that measures the electrical activity of the brain is the EEG. No other test can replace the EEG from that point of view. But important, it doesn't help to confirm the diagnosis. No, the diagnosis still remains clinical. The EEG helps you to support the diagnosis of epilepsy. Therefore, a normal EEG does not exclude the diagnosis of epilepsy, nor in a small percentage of normal people, they may have some epileptiform discharges. It can be there in a small percentage, 0.5%. Just because the EEG is abnormal does not make the patient as having epilepsy. So these two things, a normal EEG does not exclude, an abnormal EEG does not mean that the patient. So it's a clinical diagnosis. That's the first thing. Now, because, Dr. Sita and Dr. Sangeeta mentioned several, and Dr. Gagandeep mentioned several, causes, the etiology or the causes of epilepsy. Ranging from abnormalities in the brain and looking for scars and mesial temporal sclerosis and tumors. All these are structural causes. You have to understand the structural causes. You need to do neuroimaging, or, the best neuroimaging is MRI. Sometimes you can do a CT scan just to look for any calcification. But the most important test, I think, is the structural imaging is MRI. And then you need to do simple blood tests, important, points like, for example, metabolic factors, liver function, kidney function, calcium, magnesium. These are simple tests that can be done. So the three most essential tests, or the four most essential tests begins. One is in the outpatient clinic itself, smartphone, good history. The next level will be an EEG to look at the function. The next one is to look at the structure, which is this. Then only you go for more complicated testing. This is my, this is how we should approach.
Thank you. Thank you. I think you have very clearly said that clinical history taking and the smartphone, and we should be thankful to the iPhone and Android makers for making our job a lot easier with their inventions. Now everyone has a smartphone in hand. So it is actually it's becoming a real blessing in disguise in an epilepsy clinic, as in many other aspects of medicine, especially neurology. So thank you very much. And
Dr. Dinesh Nayak has made a very important point कि वो सब टेस्ट नॉर्मल होने के बाद भी एपिलेप्सी हो सकता है. बहुत से लोग पूछते हैं कि हमारा ईईजी नॉर्मल है, हमारा एमआरआई नॉर्मल है, सीटी स्कैन नॉर्मल है, ब्लड टेस्ट नॉर्मल है, फिर अटैक क्यों आ रहा है? तो फिर ये सब नॉर्मल होने के बाद भी तो हम बोलते हैं कि अच्छा है, नॉर्मल है तो बहुत अच्छा है, तो अटैक कंट्रोल होने के चांसेस बहुत ज्यादा अच्छे हैं, तो और फिर भी अटैक हो सकता है क्योंकि ये डायग्नोसिस क्लिनिकल है.
Yeah, sir, then I think you should also, to Dr. Meshram, sir, you'll also tell what percentage of people with epilepsy can have abnormal EEGs. And, people have a lot of expectations, as you rightly pointed out. In practice, the same question that you said, everything is normal, but why do I get it? So the first response I actually say is, be happy that the scan is normal. We haven't found a tumor or anything or a bleed inside your brain. So be happy for that. So, and I always use this analog that, it is like, if you look at the scan, it is looking at a picture of a man and trying to find whether it is a good man or a bad man. Supposing he has cut marks on his face and looks like a villain, he's probably a bad man. He's probably a bad man, even though you can't be sure. But if he is looking very normal, still you have to check the background to know whether he is good or bad. So you still need tests like the EEG. So I say that a normal scan is like a normal photograph. So can you, sir, to Dr. Meshram, can you enlighten people about the positivity rate of EEGs. And what are these? You use lights, you ask people not to sleep and all that before they come for EEG. Why do you do all that?
Yeah. बहुत महत्व की बात है. वो EEG एबनॉर्मलिटी जो है वो इपिलेप्सी जिनको है उनमें वेरी करता है. वो वेरी करता है क्योंकि नॉर्मल जैसे रेस्टिंग कंडीशन में अपन EEG करते हैं तो उसका पॉजिटिविटी रेट कम आता है. फिर ड्यूरेशन कितने देर के लिए करते हैं उसका एक बहुत इंपॉर्टेंट है. फिर कौन से सेंटर में करते हैं, जैसे डॉक्टर सीता जयलक्ष्मी है या डॉक्टर चतुर्भुज राठौड़ है, दिनेश नायक, वो इपिलेप्सी सेंटर में काम करते हैं. तो उनके पास जो पेशेंट्स जाते हैं वो बहुत रिफ्रैक्टरी पेशेंट जाते हैं. तो उनके यहाँ पॉजिटिविटी रेट जो है EEG एबनॉर्मल होने का बहुत ज्यादा होता है. जो क्लिनिकल न्यूरोलॉजिस्ट है तो वहां पे करीब 40% या 50% में पेशेंट्स को इपिलेप्सी के EEG एबनॉर्मलिटी देखती हैं. यदि हम उसको स्लीप स्टडी करें और अवेक स्टडी करें तो उसकी एबनॉर्मलिटी के चांसेस बढ़ जाते हैं. फिर हम रात को उसको सोने नहीं देके दूसरे दिन करें तो उसके पॉजिटिविटी रेट बढ़ जाता है. फिर दूसरा एक इम्पॉर्टेंट होता है वीडियो EEG. जो वीडियो यानी पेशेंट को अपन देखते हैं, वीडियो उसका रिकॉर्डिंग करते हैं और फिर उसका साइमल्टेनियसली EEG करते हैं, और जो अटैक आता है तो उसके साथ में EEG एबनॉर्मलिटी का कोरिलेशन है कि नहीं, तो फिर पता चल जाता है कि ये इपिलेप्सी का अटैक है या नहीं है. कभी कभी बहुत से इपिलेप्सी के अटैक जैसे दिखते हैं मगर वो मानसिक तनाव के कारण अटैक आते हैं, तो उसमें वीडियो EEG नॉर्मल होता है. तो ये समझना भी बहुत जरूरी है. थैंक यू.
Thank you, sir. Thank you. That was a very important thing. And it was very clear that you can have a normal EEG at the point. Unless you're recording during an attack, it will be very difficult to go by only a normal EEG. And so people ask, why do you do an EEG? So we have to sometimes tell them that, the EEG can give us clues as to which medicine is to be prescribed for you. And that's an important thing to start off with. So I would now
Can I just add one thing?
Ask Dr. Chaturbudh Rathore, our convener of the epilepsy subsection. And
Dr. Sangeeta wants to add something.
Yeah, and I was just saying, आपने जो वीडियो EEG बोला, that is very important point. और उसमें एक ECG का चैनल भी रहता है. So कई बार ऐसे अटैक हार्ट के रिदम की वजह से भी होते हैं. तो वो ECG चैनल जब वीडियो EEG में होता है तो उसका भी निदान हो सकता है वीडियो EEG के थ्रू. So that is one more advantage of वीडियो EEG जो है. So जब डायग्नोसिस कंफर्म नहीं है तो वीडियो EEG करेंगे तो निदान बहुत अच्छी तरह से हो सकता है, जो हार्ट प्रॉब्लम भी पिकअप कर सकते हैं.
Thanks, Sangeeta. That's an important point too. Thank you very much. To Dr. Chaturbudh, who's a consultant neurologist and epileptologist, Zydus Hospital, Vadodara. Chaturbudh, the patient has been evaluated now. Now we're in the state of planning treatment for the patient. Now, there are two aspects. What would be your broad perspectives before you take a decision on whether to treat, number one, what to treat with, number two, and number three, I think probably this must be number one, how much of the involvement of the patient is important in your decision making?
Thank you, sir. Thank you for a very big question. I think we take lectures for 45 minutes on this question. When to start medicine and what to start and how the patient should be involved. So I will try to be as brief as possible. But before going to this question, I would add to what Meshram sir has told about the yield of the EEG. And I can say that EEG is one of the most abused investigation in the clinical medicine and the neurology. So not only the various factors, patient-related factors, but it is the quality of the EEG which is done and which center it is done. It amounts a lot about the yield of the EEG. And then I would actually request the patient, there are many labs which are telling that they are doing the EEG. So that if EEG lab or if the EEG as a center has no attached neurologist or a neurologist is not reviewing the EEG, there is no meaning of that kind of EEG. And is EEG reviewing is also equally important as the technical quality of EEG. So that can increase the yield of EEG. Now coming to the question of when to start the treatment. So obviously that depends upon once the person has, when we diagnose epilepsy, only when the person has a recurrent and unprovoked seizure. The patient has a tendency to have unprovoked seizure. So this when we diagnose epilepsy only when the person has 2 or more seizures. Except in certain situations, we can diagnose.
1 minute, can I interrupt you here? And
Yes,
ask
sir, please, please.
It's a question that we often face and what patients ask us. If a patient comes to you with a single episode of unprovoked seizure, what are the chances that he will have another one?
So I would take that. So once the person has, this has been proven in the studies, once the person has 2 and unprovoked seizure, chances of getting a third seizure or a 4th seizure at the end of 2 years is as high as 80%. That is after that patient has a 2 unprovoked seizure. So that once the person has 2 unprovoked seizure, invariably it means that we need to start the treatment to prevent the third seizure. Now the question is once the person has come with the only 1 unprovoked seizure, and now in these cases the chances of having a second seizure varies from anywhere between 30 to 70%, and it exactly depends. And so in those cases, 30% is a low risk. We may not start the treatment. 70% is a high risk. We need to start the treatment. So what is the factor which determines between these 30 and 70%? To simple term, it is the underlying, what is the cause of the epilepsy, or if we can identify what is the type of epilepsy person has. So in simplistic term, which I see, if the person comes with a definite 1 seizure, I do the EEG as well as the MRI. If both are abnormal, then chances of a person getting a second seizure is more than 60%. In those cases, we usually start the treatment. If either of them is abnormal, that means either MRI or either the EEG is abnormal and one of them is normal, chances are still high up to the range of maybe 40 to 50%. In these cases, usually we decide depending upon the other factors whether to start the treatment. In majority of cases, usually we start the treatment. The patient comes with a first unprovoked seizure, and there is no clue in the history that patient did not have any other seizure, and EEG is also normal, MRI is also normal. In those cases, the chances of recurrence are usually less than 30%. In those cases, in majority of cases, we would like to wait for to start the treatment. And especially this holds true in the children, because children usually have a self-limiting epilepsy and they may not have a recurrent seizure. But in adult, it also depends upon the multiple factors. What is the age of the patient? What is the profession of the patient? And whether the patient is willing to start the treatment or not. Patient's concern, whether they want to start the treatment or not, it also very important. Some person, because they do not want to have any risk at all, then we would like to start the treatment. Other person or other patient, they may want to wait before the second seizure. So patient perspective is also very important. So that is, sir, as far as the first question, when to start the treatment. You want me to take on what factors, or you would pass to? You want? Okay, sir.
We'll pass. So we'll come back to you. We are going to come back to you.
Sure, sir.
Sure. So I think that's a nice overview what Dr. Chadrapur just told you about how we approach a patient and when and why. Maybe Chadrapur, you would want to add about the patient characteristics, his profession or something that would determine whether you are going to start on anti-epileptic drugs too.
Yes, sir. So I already alluded to that. What is the patient job profile or patient profession? If the patient is working in a high-risk group, like a construction worker who is working in or has a risk of significant hand injury. So in those cases, probably with the patient's perspective also, and we would usually like to start the treatment if the profession is a high-risk profession. But ultimately, in those cases of doubtful cases, that is only the case when the MRI is also normal, EEG is also normal, and patient has a single seizure. In those cases, usually the patient's perspective is what we take into account. And that depends upon the multiple other factors, and job is one of the important factors. And certainly what is the age of the patient is also important.
Okay. And if he is the breadwinner for the family and all that, yeah. Very important to take in all the characteristics. Thank you very much. Dr. Sangeeta, now we have taken the decision to treat now. So you reach that stage with the patient. So how do you go about choosing the medication? So what are the principles? What are the factors that you will keep in mind when you decide on the drug to be given for the patient?
Yes, it's a very important question because to choose a correct drug for a correct type of epilepsy is a prime importance, because then only you will get a good control. So there are some patient-related factors and investigations and the history. So we have to take chart of all the factors. So if you first go towards what is the type of epilepsy? So what type of seizures he has? Does he have a myoclonic seizures, focal seizures, or generalized seizures? Does he have a family history positive? Or does he have, what is the etiology wise? Does he have any metabolic problem, or he has a focal structural abnormality in the MRI? So depending on that, if you have a generalized seizure, then you prefer certain type of drugs. If you have a focal seizures, then you prefer certain type of drugs. If you have a myoclonic jerks, then you avoid drugs like carbamazepine and phenytoin and others. So first is a type of seizure, a type of epilepsy. Then it comes what is the patient factors. So whether the patient is a child who is going to school, or patient is an woman who's in a teen age and is likely to get married and have children, or is an elderly who has comorbidities. So, and also whether patient is fat, obese, he has any comorbidities like migraine, or he has any hypertension, diabetes, or he has any depression, anxiety, because often the psychiatric comorbidities are often seen because with epilepsy, because it's a chronic disorder. So depending on this patient factors, we choose the drug. If there is an obese patient, you do not choose a drug like valproate or something which is likely to increase the weight. Similarly, you may choose a drug which is zonisamide or topiramate, which is likely to reduce the weight. You may not choose oxcarbamazepine in such patient. So second factor which you can take into consideration is like a woman with childbearing age. It's a whole lot of particular drugs, only 3 or 4, which are supposed to be very safe. So you start the patient on that. Even in a young girl, there are side effects like PCODs, polycystic ovarian, with certain drug like valproate. So you avoid those drugs. So these are the patient-related factors which you have to see, and the comorbidities which you have to see. In an elderly, if there is a heart disease or something, you try and avoid phenytoin and others, and you choose drugs if they have a hepatic involvement. If they have a renal involvement, then you choose the drugs which are not eliminated by kidneys or not eliminated by liver. So you choose which are safe for that, with that comorbidity. So depending on that, in elderly, you might choose drugs which do not have a cardiac side effect, which do not have hepatic or renal side effects. And in the also the timing of the giving the medication, especially in children who are going to school. If you give the major dose in the morning, they'll be very sleepy during the school. So it is better that you divide that in the morning you may have a smaller dose, or if they're coming back by 1 o'clock, you give the morning dose that time, and the major dose could be in the night before they go to sleep. So that is also very important that you choose. You advise the dosage regime as per the schooling. So these are some of the factors which you. So apart from the seizure type, epilepsy type, the etiology, the host factors also with the comorbidities are important before you choose a drug. And and the one important thing is financial. So that's also important. These are the ideal situation where you choose. But in the end, sometimes it happens that if the patient is coming from a remote area and has just come to Mumbai for one opinion and is not likely to get the third generation drug there, it is better to start on a primary drugs which will be easily available in his hospital or nearby his village. Otherwise, the secondary treatment gap comes and they discontinue. So the financial aspect is also another major thing which you have to think before you start the anti-epileptic medication, apart from these factors.
Thank you, Sangeeta. And, I know all of you are experts with a lot of passion for epilepsy, and you're all international experts used to giving lectures. As Sajabud said, I would only request that please keep this simple so we can answer more questions too. But anyway, Sangeeta has covered at least 3-4 questions in that one shot. I was about to ask Dr. Meshram about the importance of economics and availability. Anyway, she has already answered.
I'm so sorry.
Thank you very much. No, it doesn't matter. I'm just saying, no, please don't be
As
sorry.
epileptologists, we can't stop, once the question is there, we go on and on.
Yeah, that's what I said. I know you're all very passionate, so it's very difficult to stop you all. So, but my job as moderator is part of that also. So now, if Dr. Gagandeep, can you just give us an overview of how the anti-seizure medications have shaped up over the past 3 decades?
Yeah, so that is something that is also, it's a very good question, and it's something which is very significant. So the situation is like this, that in the 1970s and 80s, 1970 और 1980 में सिर्फ 4 मिर्गी की दवाइयां अवेलेबल थी. There were just 4, perhaps maybe 5 anti-epileptic drugs or anti-epilepsy medicines which were available. So 1990s and the first decade of the current century, 2000s, there was a sudden boom, and at least 15 new drugs were introduced in the market. And the majority of those drugs are now available in India. In the last decade also, I think about 5 or 6 new epilepsy medicines have been introduced. So the number is increasing. And in a way, it is a good thing for both doctors and patients, because they have more, as they are newer medicines, so because they are newer medicines, so they are more expensive. जो नवी दवाइयां हैं वो नेचुरल है कि वो उनका खर्चा ज्यादा होगा, महंगी होगी, पर वो भी धीरे धीरे कम हो रही है. और दूसरा, जो वर्ल्ड हेल्थ ऑर्गेनाइजेशन WHO ने क्या किया कि ये ड्रग्स को एक एसेंशियल मेडिसिन लिस्ट में ले आए, तो कि इनकी जो प्राइस है, इनकी जो कॉस्ट है, वो इससे ज्यादा नहीं हो सकती, इतनी ही हो सकती है. तो अब जो इंडिया में जो पहली पुरानी 4 मेडिसिन हैं, वो हैं फेनिटोइन, कार्बामेज़ेपिन, वेलप्रोइट और फिनोबार्बिटल. तो इनकी प्राइस तो बहुत कम है, बहुत सस्ती है. अब लेटेस्ट ये है कि जो लेविटेरिसिटम है, जो एक नवी मेडिसिन है, वो भी एसेंशियल ड्रग लिस्ट में आ गई, तो उसकी प्राइस भी काफी कम हो गई है. जो नवी मेडिसिन है, उनका जो मेजर एडवांटेज है, द मेजर एडवांटेज ऑफ द न्यूअर मेडिसिन इज दैट दे हैव रिड्यूस्ड साइड इफेक्ट्स and they don't interact with other drugs. So these are the major advantages. I mean, there is no evidence to suggest that they are more effective than the older ones. And as Dr. Sangeeta said, that whenever we have to choose, we look at the type of epilepsy, किस प्रकार की epilepsy है, और दूसरी चीज, the second thing that we look at is the characteristics of the patient who has to receive the medicine. So I think these are the important things. So definitely we have a much greater choice. There are a number of anti-epileptic drugs. The newer ones are of course more expensive, but that does not mean that they are more effective.
Thanks, Gagan. Thanks for highlighting that point. And I'd also add here a news article that I read about Sierra Leone. Sierra Leone is a country in sub-Saharan Africa, and the only anti-epileptic that is available around the year, all the time, in that country is phenobarbital. And at that time, when I read about it about 8 years ago, there was only one Eeg emission in the whole country. And but still, 70% of the epilepsies were under control. So yeah, I think that reflects a lot about what you just said. I think that equates. I think the next point I would probably ask, okay, now we have started medicines. We have decided which drug depending on the type of epilepsy, depending on the age, gender, the physical characteristics, the economics, the affordability, availability, everything. Now, what if my seizures are still not controlled? Dinesh, maybe you can take this question. Tell us, what if they are not yet controlled? What would you do next?
That's a very, very pertinent point. What if the seizures are not adequately controlled? Generally, if you look at the treatment, the steps in the treatment, you normally start with the one or a monotherapy. Obviously, it's going to be monotherapy. Single drug, that's the ideal. So you choose the most appropriate medication, as has already been discussed, and you give it in the adequate, well-tolerated dose. So make sure that the dosage is adequate and up to the tolerance level. And if the person remains seizure-free, fine. But if the person fails that medication, that first monotherapy, and that is because it's well-tolerated but not effective, then you may have to add another drug. So that is what is called an add-on. Or if it is not tolerated, you change into another monotherapy trial. So that's this. But if they fail the second monotherapy, then you go into what is called a add-on therapy, and you try out one add-on therapy and then see whether that's getting controlled. If it's not getting controlled with one add-on therapy, you may try a second add-on therapy. Even that fails. That means 2 monotherapy trials have failed and at least one add-on therapy has failed. Then you call it as probably a drug-resistant epilepsy. Now, if you look at the natural sequence or history of this, it takes maybe 6 months for one to decide whether a monotherapy is failing, another 6 months for a second monotherapy, and one add-on therapy, another 6 months. Within a year and a half or 2, you can actually make a diagnosis whether this patient is a responsive patient or a resistant patient. At the end of 2 years, if a person is not responding adequately, it is best that this patient is referred to a center for evaluation, an epilepsy center. The reason is we want to catch these people early. And so this is the thing. So it takes 2 years, not more than 2 years. In very high frequency, for example, in children, in infants and young children, and they have much higher seizure frequency. You don't have to wait for that long at all. So you can make a diagnosis within a few months, saying that this is not working. So that is the way in which so ideally you should do that. So when they come to the center, or they get referred to a center, comprehensive center, it's obviously a teamwork. The new epileptologist, it's a big team that evaluates. But the most important questions that the center will ask is the diagnosis correct or not? Because a third of the patients, maybe about 20% to 25% in any center, who have so-called drug-resistant epilepsy, they actually have been found to have no epilepsy. So there are epilepsy mimics, that forms about 20%. So is my diagnosis correct? That's the first question. Second question, have the appropriate medication been tried in the appropriate doses? That's the second question. The third question is there a substrate, some etiology? What is the etiology of that? Is there a lesion that is responsible for the epilepsy? And that is by means of a good quality MRI with the epilepsy protocol specially done.
Would you want to say in simpler terms what a lesion is?
Lesion means an abnormality. For example, a lesion may be a tumor. The tumor means a low-grade tumor, or it could be a abnormally formed blood vessel. For example, what is called a cavernoma or a arteriovenous malformation. That is another cause. You may have a scar, as Dr. Sita was pointing out. During a difficult labor, There may be hypoxia, hypoglycemia, that produces scarring. So that's a lesion. So these are some of the causes of drug-resistant epilepsy. So we have to find out whether they are there or not. Once they are there, then we do what is called a video telemetry. And we have already alluded what is a video telemetry. So these are the steps in which we do. And then see whether they are good candidates for the next step, which is epilepsy surgery. So if you look at drug-resistant epilepsy, which forms about 20% of all epilepsies, if that 20%, at least half of these patients are actually potential candidates for surgery, which means that the most difficult cases ultimately can actually have a potential of getting cured or well controlled. So that is the thing. So the point is, at what point to refer? This has to be properly known to both patients as well as to the doctors. The patients also should know, okay, it's now time for me to, go, if they have not been referred, it's time for me to, seek the help of maybe a center which is, capable of investigating these patients. Very, very important. Takes 1.5 years. Earliest 1.5 years, maximum 2 years. In children, much earlier.
Thanks, Dinesh. Thank you. I think that is a very nice way to say how you will go about approaching a difficult patient. And ask this question to Dr. Sita Jayalakshmi.
Yeah, before you move on, Meenakshi.
Yes,
Dr. Meenakshi Sundaram.
Yes, sir.
We will. आप जो लोग सुन रहे हैं ये कार्यक्रम, उनके कुछ सवाल है या उनके मन में कोई शंका है, तो वो Q&A बॉक्स जो है, क्वेश्चन आंसर बॉक्स, उसमें आप अपने सवाल डाल सकते हैं, तो वो फिर उनका आंसर या उनका समाधान हम बाद में कर लेंगे. धन्यवाद.
I think there are, so in the Q&A, there are one like types of treatment, and the next point is, I'm going to ask this to Dr. Sita. We will take up, when do you consider epilepsy surgery? In short, is for the public to know, and Dinesh has pointed out the duration. Who is a good candidate in your mind, and what are the success rates? You have a center with high volumes, so maybe you can elaborate on.
Yeah, this is a very important question, which most of the time we need to inform the patient as well as the family members before we consider the option of surgery. Like already told by Dr. Dinesh Naik, surgery is ideally considered in those who have drug-resistant epilepsy, means having daily seizures or weekly seizures or at least 2 per month. That is just to say, and are those with, though infrequent, interfering with their activities of daily living. Usually it is 6 months because of high seizure burden in children. And like he said, it's 2 years in case of adults. And once they come, the first and foremost is the good history. After that, you do a video EEG to rule out non-epileptic events or so-called functional seizures. But the persons who have the best outcome after evaluation is those who have a clear-cut lesion and MRI. Like we already discussed, it can be a hippocampal sclerosis on MRI, which is the commonest in adults, or it is a focal cortical dysplasia, which is developmental abnormality in a small part of the brain, especially in children. In addition to this, like we discussed, the others can be like a malformation in the blood vessels, that is cavernoma, or it can be slow-grade tumors, the so-called DNET and gangliogliomas, which we see, or sometimes scar-related epilepsies, which are also present in a focal area, I mean it's in a small area. Sometimes the scars can be very extensive, then they may not be suitable. Then the other candidates are those who have entire one half of the brain which is affected, that is called hemispheric epilepsies, again which can be a scar because of childhood strokes, or it can be because of, again, abnormality of development of one half of the brain. So these are sometimes, even if multiple parts of the brain are affected, they can undergo some disconnection procedures. So these are all the clear-cut candidates for epilepsy surgery. So based on, so finally the success rate depends on picking up something on their MRI. Though we operate patients who do not have anything in MRI by doing advanced tests like stereo EEG and all. But those who have a clear-cut lesion on MRI do have good outcome, because the outcome is not at the end of 1 year or 2 years. It has to be at the end of 10 years and 20 years. Normally, if there is a clear-cut lesion on MRI like hippocampal sclerosis, the immediate outcomes, that is at 1 to 2 years, is almost more than 70 to 80%, becoming seizure-free. And usually we make them continue the medications for up to 1 year. And after that, we start down titrating, reducing the medication, and gradually stop one medicine after the another and try to stop. In hippocampal sclerosis, up to 1/3 of the persons who are seizure free will be out of medication. That is, if the success rate is around 80%, 25 to 30% will be able to stop the medication. The rest of the people will be seizure free, but they may get 1 or 2 seizures on reducing the medication, and we continue those medications, but their medication burden comes down drastically. Instead of taking some 6 tablets or 8 tablets per day, they will come on to possibly 1 or 2 tablets on the medication and become seizure free. Whereas for others, like even for focal lesions, it appears, but in case of cortical dysplasias, the success rate comes down because we call them as a network abnormality. So the success rate is around, I will say, 60%, depending on the type of, again, what is the cortical dysplasia.
Overall, where would you put the success rate now? If you want to say grossly, what range would be?
It varies between 60 to 80% based on the histopathological examination.
So I think the message is clear that about if 5 people undergo surgery, at least 3 to 4 are very likely to get better. So if that reaches people, I think that is fine. I now turning to Dr. Chaturbhuj. Chaturbhuj, now we'll talk about the treatment per se. There's a question in the Q&A too. How long would you want a patient to take medicines? And what are the do's and don'ts while taking medicines?
Okay, sir. So I would add to the whatever the discussion going on. Any person who is not getting control with the medicine, if you are a person with epilepsy and if your seizures are not controlled with 2 medicine, always consider that epilepsy surgery is an option, and that has to be kept in the mind. Or even if epilepsy surgery is not possible, you should get evaluation at a comprehensive epilepsy center where your epilepsy can be more properly diagnosed or managed, or sometimes the attacks mimicking epilepsy can be diagnosed. So if your seizures are not getting control with the medicine, please take the help of comprehensive epilepsy care center. So, sir, coming to your center, how long, what should be the duration of the epilepsy treatment? So it varies, and the most important factor which decides whether you should take the treatment or how long the treatment should be taken is what is the underlying cause for epilepsy, or what we call as epilepsy syndrome. So there are certain conditions, especially in the children, where they are what we call is self-remitting epilepsy. The epilepsy medicines, what they do is they just control the seizures. They are anti-seizure medicine. Epilepsy medicines are not going to cure your epilepsy. The epilepsy gets cured with natural history and with the natural progression, and in some patients, especially in children, as the age advances. So in some children, there are what we call is self-remitting epilepsy, that after a few years, maybe after 1 or 2 years, your epilepsy gets remitted and with medicine can be stopped. And majority of the other cases, there are other extremes also, and especially what we call is juvenile myoclonic epilepsies, or certain very difficult to control epilepsy in children. There we cannot stop the medicine and they require medicine probably for a longer period, and in some cases maybe the lifelong. But this applies where the medicine can be stopped after 1 to 2 years, and whether the other extreme is where the person wants to continue the medicine. This happens in only 20% of the cases. 80% of the cases where there is no clear-cut answers. In those cases, what usually our dictum is that usually we give the medicine for a period of 3 to 4 years. If the person doesn't have seizure for a period of 3 to 4 years, then we presume that the epilepsy or her epilepsy has been cured, and we will try to stop the medicine. Obviously, we will do the investigation, the EEG, before stopping the medicine. But a rough guide, if the person has not a known epilepsy syndrome, where you don't have epilepsy which is self-remitting, or epilepsy which is usually a lifelong tendency, then in those cases, usually after a period of 3 to 4 years, we try to stop the medicine. That doesn't mean that every patient will come out of the medicine, but if you fall into the category of unknown epilepsy and in which you are seizure-free for 3 to 4 years, chances of stopping medicine are approximately 60 to 70%.
Right. Thank you, Chaturbhuj. That was.
Can I add one point?
Sir, next is coming to you, sir. Next question.
Okay.
Now, after the essay questions, we are now moving to one-word answers. So now is time for, like they say in the Karan Johar show. So this will be a rapid fire. So these are questions that patients ask us regularly. So I'm going to start off with Dr. Meshram. Is epilepsy a hereditary disease?
It is in very small percentage. This is a very common misconception that people have, that epilepsy is hereditary, but that history of hereditary is present in only about
very
3 to
commonly
4% or 5%.
So very commonly they want to know whether their children will get the disease.
Yeah.
Yes.
So that is a misconception, because people are worried कि mother को epilepsy है तो बच्चे में आ जाएगा, फादर को epilepsy है तो बच्चों में आ जाएगा, तो फिर epilepsy जिसको है उसके साथ शादी नहीं करना, उसकी शादी नहीं होना चाहिए. तो ये अब 4-5% तक ही हेरिडिटी रहता है. बाकी जो 95% है epilepsy वो हेरिडिटी नहीं होती है. तो ये समझना बहुत जरूरी है. तो उसके कारण जो डर है मन में कि ये हेरिडिटी या बच्चों का आ जाएगा, ये मन से निकाल देना चाहिए.
Thank you, sir. Dr. Gagan, now if someone is convulsing, what should the first aid be? What should one do?
The immediate first aid that is required is, the first thing is we need to ensure the safety of the person. And if the person is actively convulsing, I would put something under the head, maybe, put my hands under the head, or maybe a pillow or something. And we should ensure that there is nothing around which can, impact the safety of the person. He's wearing a tie or a tight coat or something, loosen his clothing. That is extremely important. Once the seizure stops, that is the convulsive movement stop. So all we really need to do is to ensure the safety of the person. And once the movement stop, we can then turn over the patient to one side, either right side or left side, and strike his back a little with your hand. And the idea is that the tongue should not fall back, and if there are any secretions in the mouth, they can come out. So that is the most appropriate first aid that we do.
Thanks. I think that's something that people should realize, not insert anything into the mouth, not give iron rods in the hand, not make them footwear. So please don't do all that. It's not right. And now I'll move on to Dr. Dinesh. Dinesh, tell me the important points about epilepsy in women of childbearing age. What are the important points to keep in mind?
You're muted.
You're muted, Dinesh.
Yeah. I think now I'm all right. Yeah, thank you. That's a very, very important point. Women of childbearing age, I assume that they are going to get married. So the first thing is that we should encourage that they should reveal their problem to the potential, the spouse side. And that's very important, because if you hide and then they get into trouble. The points are that you have to choose your anti-seizure medicine appropriately. Avoid valproate. We have already discussed that. Choose something which is safe during the planned pregnancy. That's an important point. There are many safe medicines, both in the older as well as in the newer generations. So choose the right medication and start folic acid as soon as they get married, right from the beginning, because you never know when they're going to get pregnant. It could be just the first week itself, and by the time they realize that they're pregnant, it's already the first 6 or 8 weeks are over. So organogenesis has already happened. So folic acid is a very important point. And then, so there's a lot of pre-pregnancy counseling that has to take place. We have to assure the patients that, whatever anti-seizure medicine that is going on, the impact on the growing fetus is only to the tune of about 5% on an average. If you remove valproate from the business, then it is only about 5%. Whereas even in a non-epilepsy person who's undergoing a normal pregnancy, the chances of getting some kind of a fetal malformation is about 1 or 2%. So you're only talking about, you're comparing between 2% and 5%. 95% of the time, they're going to have a normal baby. So that's the most important message that we have to provide. Look after you. I think the physician has to take full control. Assure the patient that, most of the time the pregnancy is going to be all right. Follow them up.
Even
yeah.
in a person who is not on any drugs, the incidence of some form of congenital defects is going to be around 2 to 4%.
Yeah, 2-3%.
Yeah, and if you're adding an anti-epileptic drug, you're taking a drug, it only goes to about 5 to 6%.
5 to 6%. In absolute terms, it is double.
Yeah.
But in the totality of it, it is still only, there's a 95% chance of normal.
Normal delivery.
That's a very important point.
Yes.
So
that's a very nice answer, and these are important points one would take. So then there are other questions that are commonly asked. Dr. Sita, can a person with epilepsy drive?
Yeah, this is a very important question, and most of the patients in the OPD ask, can I drive? Actually, those who have active epilepsy, means getting frequent seizures, definitely should avoid driving, because it is the safety of the person which is very important. So there are driving laws in various other countries. In India, still we do not have any specific laws, but extrapolating from other countries as well as for the safety of the person, one can drive if he is seizure-free for 2 years and is willing to continue the medications. And whenever we are after seizure freedom of 2 to 3 years, when we are reducing the medication, again we advise them not to drive at least for a period of 6 months, because the recurrence rates are highest in the first 6 months.
Thank you.
So otherwise there is nothing like black and white.
Okay, wonderful. I think that's very important for everyone to note. That's very, very important for the safety of the person as well as those on the road. Chaturbuj, can a person with epilepsy marry?
Sir, one word rapid fire question is absolutely yes.
Yes. Thank you.
There is no contraindication for marriage. They can lead completely normal married life.
Very good. I think
Agreed.
that's the best.
Why not?
Yes. Yes is the right answer, and it's the only thing to remember. Is there any effect of a particular diet? Maybe Gagandeep can answer this question. Is there a specific diet? People often ask, as they're on the way out, they always ask, what about my diet? Is there something that you want to tell me?
Yeah, for an average person with epilepsy, my answer, I mean, that is a question which is always asked, at the end of the consultation. So I tell them that, yeah, there is nothing specific. You just have some healthy food, and all the principles of healthy food should be followed, clean and healthy food. But what is important to note is that particularly for children who have difficult to control epilepsy, where these seizures have not been controlled with whatever medicines, and several of my esteemed colleagues have discussed a situation which is called as drug-resistant epilepsy, where the epilepsy does not respond to epilepsy medicines. And so in that kind of situation, there is a diet. It is called as the ketogenic diet, and there are lots of variations of this diet too. And basically what this diet does is, there are two things. You have to be really strict, which is very difficult with children. I mean, you can't tell children not to eat that and not to eat this. And the second thing that is very typical of the diet and birth doing is that carbohydrates or carbs are dramatically reduced or virtually absent in the diet. So it comprises of fats and proteins. So yes, this diet is there, but it is only reserved for children with difficult or drug-resistant epilepsy.
So that's great. So if we were to summarize, I think you clearly said that unless it's a drug-resistant epilepsy, where your doctor advises you to be on a particular diet. There is no diet that is a dietary change that will be required. Whatever you're eating, normally you can continue to eat. So there is something that many patients do ask about some drugs, especially Dinesh should know. They will say that it produces heat in the body, so don't take fruits, don't take curd. There's so many myths. So that takes us to the question, Chaturbuch, we can tell us about this. What are the common myths? And what do you think, what myths would you like to break with this forum?
Okay, sir. So this is cannot be one word answer. So I will take. Okay. So, sir, the commonest myth is that people believe that epilepsy is a uncurable disease and it cannot be cured, which is a completely myth. With the availability of newer medicine, epilepsy can be controlled in almost 70% of the patient, and in the rest 30%, majority of patient can get benefit with the epilepsy surgery if it is possible. So people with epilepsy can live completely normal life. They can lead, there is no problem in their children, don't have any problem in the education. Women with epilepsy can marry and can give birth to the normal healthy babies. And all the people can do their normal routine occupation and employment. There is no problem at all. People with epilepsy can play cricket. They have played international cricket. People with epilepsy have won gold medals and silver medals in the Olympics. People with epilepsy have become the world famous painters and world famous artists. So epilepsy in no way is going to cause any problem in your life in majority of the patient. Only problem is when the epilepsy is not getting controlled, and that is a small proportion of the patient. The other myth which I have already taken, that epilepsy people cannot live a normal life, or they cannot marry, or they cannot have a normal employment, or the children with epilepsy are dull, and this, which is also a completely myth. Epilepsy people are as normal as any other normal human being, just like me and you. And if the person doesn't tell you that he or she has epilepsy, this person may be working with you or studying with you for more than 5-10 years, and you will not know that the person has epilepsy. So then certain other things which is a myth is that epilepsy is a contagious disease, or can be spread by the touch or by sharing the food, which is also a completely myth. Epilepsy is a brain disease. It is not a contagious disease. It doesn't spread if the children plays with the person with epilepsy or child with epilepsy or sharing the food. It doesn't spread with that. So, and apart from that, Dr. Gagandeep has already told there are myths that if the person has a seizure, you put some thing into the mouth, or if you could give an iron rod, or sometimes in some culture, if you beat the people, or if you put a footwear in front of the nose, so that the epilepsy or seizure can get controlled, which is a completely myth. 99% of the seizures or convulsions stop in a period of 1.5 minutes. So that if you have to just protect the person, to save the person from the injury, do not panic, and do not do anything, this kind of extraneous activities. I think I will stop at that. Thank you, sir.
That's really wonderful. That's really wonderful. You, in short, summarized all the common myths and given clear explanations. Thank you, Chaturbuj. I think that's a very, very important part of the whole discussion.
One more myth that people think, especially in the villages, ये देवी का प्रकोप है या भूत प्रेत कैसे आता है, या ये नहीं आता है, वो ब्रेन की बीमारी है. वो कोई देवी देवता प्रकोप, और वो उसके कारण कुछ लोग वो बाबा के तरफ चले जाते हैं ये मिर्गी का इलाज करने.
This is black magic.
Yeah, so that is important.
Perfect, sir. So, Dr. Mishram, we talk about, since you mentioned that, we'll also talk about epilepsy and psychiatric disease. What is the relationship between the disease and psychiatric components, and the medications that we use and psychiatric components? Do you want to briefly elaborate on that? Hello? Could you hear me?
I think his internet is
Can you hear me now? Am I audible?
Yes, sir. Yes, sir. We can hear you.
Yeah. So, Dr. Meshram, maybe, okay. I'll pass on this question to Dr. Sangeeta then. Sangeeta, can you answer the question?
Yes. So, Epilepsy is sometimes associated with psychiatric disorders, especially anxiety, depression, and sometimes you also have something called as epileptic personality. Now, this it also comes as a side effect because it's a chronic disorder and they can't adjust to the environment around. And definitely you do have some restrictions in your life when you are having an epilepsy, like you can't go late night, you can't drive, you can't go swimming easily. So all this does lead, it is situational also, but at the same time, de novo also they can have a depression. So it is important that when you patient comes to you in the beginning, you ask a few questions which may tell you whether this requires a separate psychiatric consultation. So you may refer him to the particular psychiatrist or a counselor if you think it's where the counseling is going to help. And then because it also has that it's certain drugs can also have an effect on your mood, and certain drugs are good for your mood. So when you have certain things in the history in the beginning, you choose a drug which is going to be beneficial to his mood also, like you have a mood stabilizer drug like valproate, lamotrigine, may be used better. But at the same time, if you feel that patient has an irritability, anger issues, stubbornness, and anxiety is quite a lot, then you do not choose drugs like levetiracetam or some, these are likely to increase this, exacerbate these things. So it is important when you're choosing the drug, as I said, the comorbidities, one of the important things is psychiatric aspect of this, because these drugs do have a side effect. And the commonest thing is that they feel drowsy, but you tell patients the drowsiness usually is in the first 1 or 2 weeks when you're starting a new drugs. And slowly the patient's body gets used to that. And then later on, most of the time, definitely some sleeping hours are longer than the usual person. They may require 8 to 10 hours of sleep instead of 7-8 hours. But later on, they manage to have this. So it is important to tell them not to stop the drug just because they are feeling drowsy with this. But the psychiatric side effect, you should evaluate at the beginning and then take the judgment of the which drug to choose, and whenever required, refer them to a psychiatrist.
Thank you. I think that summarizes the correlation or the interplay between epilepsy and psychiatry. I think we'll take up the last questions. We are into the last 4 minutes. Dr. Dinesh, is there a cure for epilepsy?
Well, by definition, epilepsy is a chronic condition with a tendency for recurrent seizures. That's the basic definition. But yeah, I mean, if somebody who has been seizure free for 10 years and is medication free for 5 years, the current definition says that you have your epilepsy, what is called, resolved. Your epilepsy is resolved. It doesn't mean, it doesn't say you're cured, but your epilepsy has got resolved. Now, why they use that word is because there is a tendency for some kind of an epileptogenesis, which is there. And there may be a possibility of a recurrence at some point. But that is in general. But, these are true for, some of the epilepsy syndromes. But, for example, yes, you take benign conditions, self-limiting conditions. Let's not use the word benign. The self-limiting conditions in childhood, which starts at a certain age, maybe at age of 5 or so, benign Rolandic epilepsy. By the age of 12 or 13, they are cured. They just come out of it. They're resolved forever. That's it. That's the end of their epilepsy. So there are a large group of patients who are like that. And if you look at natural history itself, 20 to 30%, they get controlled with just one medicine. They become all right. And then you can actually stop the medicine over time and they are all right. In another 20 to 30%, whether you do or not do anything, they get resolved spontaneously. And that's what that group I was telling about. So about 60% or 70%, yes, they are, you can call them as they get resolved. And by extension, many of them actually get cured.
Thank you.
That is how I will look at it. So,
That's a very optimistic way of telling people. I think that I hope this message reaches everyone. May I now request Dr. Gagandeep to please sum up the discussion for the benefit of people. I think you're muted, Gagan.
Yeah. So I think it has been a great, thank you, Dr. Meenakshi Sundaram, and I think it has been a great session. We have had some of the real gems of advice, starting from what is epilepsy, what are seizures, what are the causes of seizures, what are the various options for treatment of seizures, and also what are the if medicines do not work, then what are the options for proceeding further. I mean, the bottom line is that there are a range of options for treatment, and a good majority of people with epilepsy can enjoy a normal life. They can do whatever they want to do in life. They can achieve their dreams. They can chase their dreams. They can, become whatever, so many famous people have achieved so much. And there is no reason why people with epilepsy cannot do that. There are some important points, and these have been highlighted by the experts, including, for instance, what are the special issues for women with epilepsy. But there is nothing that is not surmountable. That is nothing that is insurmountable. There are important issues. First aid for epilepsy has been discussed. So these are few of the important things. And I think that the world is yours. This is what is the message of the experts, Dr. Sangeeta Rawat, Dr. Dinesh Nayak, Dr. Chaturbuj Rathore, Dr. Meshram, and Dr. Sita Jayalakshmi, as well as our very good moderator, Dr. Meenakshi Sundaram. So I think the world is yours. That's what our message is to everyone with epilepsy. Do what you want to do, achieve your dreams. Do not think that epilepsy would be ever an impediment in what you want to do. Is that, sorry if I've been a little short and sweet, but is that okay, Dr. Meenakshi Sundaram?
That's very sweet.
Right, thank you.
Wonderful. Thank you very much. Dr. Meshram, sir, would you want to say?
Thank you very much. I think we had a wonderful session, and thank you, Dr. Meenakshi Sundaram, Dr. Nirmal Surya for inaugurating it, and Dr. Gagandeep Singh, Dr. Sangeeta Rawat, Dr. Dinesh Nayak, Dr. Rathod, Dr. Sita Jayalakshmi. Everyone, everyone is expert in the field of epilepsy, and I think the audience would have immensely benefited. And this session will be available on the YouTube. So whenever you want to watch, you can watch on the YouTube. Thank you very much. Thank you all.
Thank you, everyone.
thank you.
Thank you. Thank you. Well moderated.
Thank you.
Good questions.
Beautifully
Thank you. Yeah,
moderated. And
Yeah,
it's a
very
great
well.
privilege to
Thank you,
share.
sir. It was a great.
The questions. So I have no.
Yes, yes.
Thank you.
Yeah.
Chaturbuj
Thank you very
especially,
much.
Dr. Sita. Thank you very
Yeah.
much.
Thank you,
so
sir.
much. Thank you.
Meenakshi is a wonderful moderator.
Excellent moderation, sir.
Yeah.
Thank you so much.
Yeah, very well.
Good.
Thank you.
Thank you. Thank you, everyone.
Thank you.